Alright, what's up guys? So, I actually did this video already live and then I deleted it by mistake. I just kept clicking on stuff that wasn't supposed to be clicked on. So I'm just going to record this one more time. This is actually the 9th video of Psych Pathology, where we were now supposed to talk about the psychoactive drugs, how to understand whether you're intoxicated or having withdrawal, and really memorizing the concept of pupillary dilation versus constriction. So in the last video, we talked about a bunch of different psychiatric emergencies, right? Anticholinergic, overdose, serotonin syndrome from side effects of like SSRIs, neuroleptic malignant syndrome, and then cholinergic toxidrome, also called organophosphate poisoning, which you normally see in farmers as far as step 1 is concerned. So each one of these has a lot to do with, truly understanding the receptors and what they're supposed to do. These receptors are directly related to the whole concept of cholinergic toxidrome and anticholinergic toxicity, because these are all mainly cholinergic, especially the parasympathetic stuff here. So what you're supposed to understand is that, if you have cholinergic toxidrome, where you have an anticholinesterase poisoning, right? So you don't have any way to stop the excessive acetylcholine. All of that acetylcholine is going to upregulate your parasympathetic activity, mainly the M3 stuff, right? So you can see increased lacrimal, sweat, salivary, and gastric acid secretion, more gut peristalsis leading to diarrhea, bladder contraction leading to urination, right? Bronchoconstriction, pupillary meiosis, ciliary muscle contraction, and more insulin release, which can make you very weak, and then endothelium-mediated vasodilation. Now, the pupillary meiosis should not be something you have to memorize, okay? It's parasympathetic. Parasympathetic always means rest or digest, right? And when you're doing something that's rest or digest, you're not trying to fight someone, right? So when you're sleeping and you close your eyes and you're just knocked out, generally speaking, your pupils will constrict because you're relaxed. Compare that to the fight or flight aspect of things. When you're ready to fight someone, your pupils have to dilate because they have to let in maximum amount of light so you can see what's happening, right? Or imagine like running away from someone in a dark forest or something, right? Everything's dark, your pupils have to dilate so you can actually get away from the person you're trying to escape from. If you've ever seen a cat, right? You can look at a cat video if you don't have experience with having a cat. But when a cat is getting ready to like play with a toy or chase a mouse or anything like that, their pupils blow up, right? Because they're just like focused on this exciting adventure of chasing a cat or going after a toy they're playing with. So what you want to remember is sympathetic activity always dilates your pupils, right? Your pupils would dilate when you have sympathetic activity because you're really trying to like catch something or fight somebody, and you need to be able to see everything, right? So when your pupils dilate, more light comes in and you can see everything. But when you're in your rest and digest phase, your pupils constrict. You don't really need to see much at all. You're just relaxing, right? There's nothing that you're worried about. And in cholinergic toxidrome, all the rest and digest things activate because you have excessive acetylcholine. Whereas over here, anticholinergic overdose, mainly we're going to see this with atropine overdose. You're going to get the whole, red as a beet, dry as a bone, all of that entire mnemonic thing. And all the acetylcholine things stop, right? So we talked about all of these things before, and we understood that when you have no acetylcholine activity, right, then you're in sympathetic mode now, and you're going to have dilated pupils. So where these things become a little more difficult is that, there's only 4 depressants for the most part, but the withdrawal symptoms of a depressant can often mimic the stimulation symptoms of intoxication symptoms of a stimulant, right? The withdrawal of a depressant will very much mimic the intoxication of a stimulant. So it's very important to get the background of a patient, see what they've been doing, who they are, what their job is, and where they were, how they're acting, all of these things to really figure out what psychoactive drug they might be worried with. So for depressants, the left column is intoxication, right column is withdrawal. You have non-specific things that are going to be pretty much seen in all cases: alcohol, barbiturates, benzos, and opioids. For intoxication of a depressant, you're going to have mood elevation, right? Because what happens with the mood elevation aspect is that you're taking a depressant that's supposed to help you get a little like relaxed and bring down all the bad feelings, so the good feelings can become really, really overpowered. Decreased anxiety, more sedation, behavioral disinhibition. You're not going to think much about what you're about to do, and respiratory depression. All right. But withdrawal symptoms, non-specific withdrawal symptoms of a depressant are going to be anxiety, tremors, seizures, and insomnia. Pretty much the opposite. So with alcohol, which is probably one of the most high-yield topics you're going to see on your step one, intoxication with alcohol is something that we've all probably experienced at some point or seen others experienced. Uh, Emotional lability, slurred speech, ataxia, that's the main common one. Blackouts from just drinking way too much, right? That's why this is under intoxication. Serum GGT is the sensitive indicator of alcohol use. And as far as liver enzymes, AST is the sensitive one for alcohol, because AST is going to be double the value of ALT. So you can remember this, toast to alcohol, or you can remember AST stands for alcohol, scotch, and tonic, something like that, all right? Now, withdrawal symptoms, this is the stuff you see mainly in hospitalized patients. Often the question is going to start with something, and you're going to start, mapping your mind into that direction, and then all of a sudden things turn around. So the question might start with a guy who had a really bad car accident, got hospitalized. They'll give you all this information about the procedures they had to do to him, what medications they gave him, etc., etc. And then the next day they'll tell you that the patient has, diarrhea, a lot of agitation, they're sweating, heart rate is up. What went wrong? Right? And then you're going to be confused because you're going to be like, wow, which one of these medications could have done that? Or what could have gone wrong in any of these procedures? Something like that. But you want to be very careful not to get confused like that. All that's happening with this patient is that they haven't drank in a while and they're having withdrawal symptoms. Now, these time spans here are pretty wide, right? 3 to 36 hours. So you can have this within 3 hours, or it can take up to 36 hours for these symptoms to show up. The reason these time spans are so big is because it's related to how much of an alcoholic you are and how long you've been an alcoholic. So if someone just recently became an alcoholic, withdrawal symptoms won't kick in within 3 hours. It might take up to 12 to 24 hours. If someone's been an alcoholic for a year or more, their withdrawal symptoms kick in within 3 hours. Within 3 hours. It just happens as soon as they haven't had a drink. In fact, a very chronic alcoholic will often carry a tiny shot, a shot bottle, and what they do is they'll constantly sniff it, take a little, just a little drop on their tongue, and they're gonna be okay, and they'll just keep doing it all day to sustain themselves, basically. Right, so that's something that you might have seen in movies. You might have seen. I think if you ever saw Bird Box, I think that was the name of the movie, right? Bird Box, yeah, where they're all blind or they have to be blind so that they don't see the nightmare thing. There was a guy who was an alcoholic in that movie, and he carried a tiny bottle with him that he would just take a tiny sip every hour or two to make sure he doesn't have his alcohol withdrawal symptoms. Now, these withdrawals can get really bad because, you see, within the same 36-hour period, you can also get these other symptoms, right? Everything up to alcoholic hallucinosis. In fact, within 24 hours, right, all of these require the minimum of 12. In 12 hours, right, within 12 hours, you can have hallucinosis, withdrawal seizures, insomnia, GI upset, diaphoresis, all of this. One thing to keep in mind, though, in alcohol withdrawal, where you're not drunk, orientation is intact, okay? In the first 48 hours, orientation is perfectly fine. It's in delirium that you become delirious and everything falls apart. But up to the first 48 hours, orientation is intact because you're not drunk. So you are able to think correctly. You are able to, process what's happening. You are just having these really bad symptoms. And we're going to talk about why these symptoms occur at the end of this video, because that's the last topic in Psych Path. The next depressant are your barbiturates, which you're supposed to pronounce as barbiturates with the D, because barbiturates increase the duration of how long chloride channels are open. Whereas benzodiazepines with the Z's are supposed to remind you of speed, benzodiazepines increase the frequency of how quickly chloride channels open. Now, barbiturates are really unsafe. They're not the best medications to use at all. They have a very low safety margin, and they can cause marked respiratory depression, which can be fatal. Treatment is just symptom management. So if someone becomes intoxicated with barbiturates, overdoses on barbiturates, possibly trying to commit suicide, you can't really do much at that point. Just assist their respiration, increase their blood pressure, and then just symptomatic aid, and that's really it. Delirium, life-threatening cardiovascular collapse, right? Things that happen after you become addicted to barbiturates and you stop taking it. Because remember, barbs, benzos, alcohol, they're all GABAergic, so their withdrawal symptoms can cause seizures. They're all very similar. Okay, and also look right here. For alcohol withdrawal symptoms, you can give benzodiazepines. So that tells you that benzos work very similar to how alcohol does. Benzodiazepines compared to barbiturates are a lot safer, greater safety margin. These overdose of benzos can cause ataxia, minor respiratory depression, and there is a medication to actually treat it. You can use a benzodiazepine receptor antagonist called flumazenil, right? But it's rarely used because it can precipitate seizures. But if you have to use it to save someone's life because they're overdosed, then you use it. Withdrawal symptoms are not that big of a deal here. Opioids are probably the biggest deal in this entire list, right? Because this has become a really big pandemic, epidemic, everything in all of medicine all over the world. Opioid abuse and death from opioid overdose is a really big issue. Overdose can cause euphoria, respiratory and CNS depression, which leads to death, decreased gag reflex, which means you end up swallowing stuff into your lungs and you can die, pupillary constriction because you're completely relaxed and pain-free, right? So you don't need to see anything, you're not fighting anyone, and seizures, right? Most common cause of drug overdose is death, which is why this is going to be on your step 1 for sure. Treatment of someone that just presented with intoxication is to give them naloxone immediately. Withdrawal symptoms from opioids present like the flu, right? So you're going to see sweating, you're going to see dilated pupils. Why? Because you're ready to fight someone, right? You're going to fight someone. If you have to beat the shit out of someone to get more opioids, you will do it, right? So opioid withdrawal always has dilated pupils because you have to let in maximum light to fight someone or find opioids. You also start seeing piloerection, rhinorrhea, lacrimation, a lot of yawning, nausea, stomach cramps, diarrhea, like completely flu-like symptoms. And one of the other things you'll definitely see is that they're going to complain of a lot of pain. It's not that they have pain, but they feel something, or they're lying, right? Either one is going to be a case scenario that you're going to see. And treatment is symptom management, methadone, and buprenorphine. We're going to see how these work pretty soon. But we've talked about buprenorphine already when we discussed opioids and their mechanism of action when we were doing neuropharmacology, right? And buprenorphine was the partial agonist. So this is a very unique opioid that you can give to help someone slowly stop getting addicted to opioids. However, if you give buprenorphine with the full agonist, like morphine or something, then it can precipitate withdrawal symptoms because the buprenorphine and the morphine are going to compete. So suspect opioid overdose in any patient who is unresponsive to voice, has pinpoint pupils, cardiorespiratory depression, and appears pale with blue-purple fingernails. Withdrawal patients will have extreme pain and flu-like symptoms, dilating their pupils for fight or flight. Excuse me. Alright, so that's it for your depressants, right? Not that many. Stimulants are a lot more. So with stimulants, you're going to notice they don't really have many withdrawal symptoms, but they definitely have very key intoxication symptoms, and that's usually what the problem is. Because with stimulants, unlike depressants, with stimulants you don't necessarily get addicted to them. There's only 2 that you can really get addicted to, and it's caffeine and nicotine. Right? The others are pretty easy to stop using, and they don't really have major withdrawal symptoms. So non-specific symptoms are always going to be there, though. So with the stimulants, intoxication will always cause mood elevation, low appetite, psychomotor agitation, insomnia, cardiac arrhythmias, which can kill you, tachycardia, and anxiety. And all of them have non-specific withdrawal symptoms of a post-use crash, depression, lethargy, more appetite, sleep disturbance, and vivid nightmares. Right? So don't get thrown off if these things are in questions. These are pretty relevant. Amphetamines. When you overdose on an amphetamine, you get euphoria, grandiosity, pupillary dilation. Okay, because remember, amphetamine is a stimulant, and now you're really, really stimulated to fight somebody. Prolonged wakefulness and attention, hypertension, paranoia, fever. Right, the hypertension is also going to be very key in a question scenario for you to be able to figure out that someone overdosed on amphetamines. Skin excoriations are seen with methamphetamine use, right? So this is where we talk about when we say, oh, this guy must be addicted to meth. And if you look at pictures online, you can Google it. People who used to use meth before and after, you can see the before and after pictures. And you can see that the skin discolorations only even occur on the face, and the person starts looking like shit. Severe symptoms can be cardiac arrest and seizures, where the patient can die. Treatment is to use benzodiazepines again, just like you did with alcohol withdrawal, for the agitation and seizures. Okay, it can help there. And this is actually an AMBOSS question relevant to amphetamine use. So you have to remember who would have amphetamines, right? Because you can't just buy them. So someone who has a family member with a scenario or a condition that would require amphetamines, like someone with ADHDs in the family, or even students. That's the most common scenario. Students can get amphetamines to, be able to study throughout like their finals week and stuff like that, and really prepare themselves for exams. And amphetamines are also sometimes prescribed for weight loss, okay, because they do decrease appetite. So this question right here, 24-year-old graduate student is brought to the emergency department by her boyfriend because of chest pain that started 90 minutes ago. Her boyfriend says that she has been taking medication to help her study for an important exam and has not slept in several days. On exam, she is diaphoretic, agitated, and attempts to remove her IV lines and ECG leads. Her temperature is 99.7, pulse is 128, and blood pressure is really high. Her pupils are also dilated. The most appropriate next step in management is the administration of what? Excuse me. So here you would just give lorazepam, right? You can tell from the fact that this is a graduate student, the fact that this patient has hypertension, dilated pupils. So those are three really key things right there. And then the whole presentation on exam, especially the removing IV lines and ECG leads, like you must be really manic, right? Mood elevation, really manic activity right there. All of that gives away the fact that this is most likely amphetamine overdose. Patients with symptomatic stimulant intoxication should be treated with benzodiazepines such as lorazepam. Benzos provide a sedative effect to help control the hypertension and prevent the seizures. Right, so really helpful scenario right here to really understand how you're going to see amphetamine overdose on your test. Caffeine shouldn't really be on this list, but it is a stimulant and it can be abused, I suppose, but it's one that we all accept, right? Everyone drinks coffee. I do it all the time when I'm streaming. How much you drink and how much you can handle is very different for every single individual. So it's not like a defined overdose per se. Some people are very sensitive to caffeine. Others, you can have 3 to 4 cups a day and still not have major symptoms from it. So overdose symptoms are very rare, but the withdrawal symptoms are pretty common. Right? Someone who likes having coffee every day and is possibly addicted to coffee will have a headache and difficulty concentrating without their caffeine intake for the day, right? But not the most significant thing. Cocaine, however, is a really big issue because people die from using cocaine, and it's almost guaranteed that someone who's a chronic user of cocaine will eventually die. They die of sudden cardiac death. So how does cocaine work? Overdose with cocaine is going to lead to impaired judgment, pupillary dilation, hallucinations, including tactile hallucinations, paranoia, angina, sudden cardiac death. Chronic use may lead to perforated nasal septum due to the vasoconstriction and resulting ischemic necrosis. So the way cocaine is used or taken is by inhaling it in through your nose. You have to just breathe it in straight to your head. So there's no other real way to take cocaine, and people who use it regularly all the time will have vasoconstriction in their nasal blood vessels, causing it to perforate, right? So they're going to have nosebleeds, random nosebleeds all the time. Treatment of cocaine overdose is to use benzodiazepines again, right? So this is great that everything is benzo so far. And also consider a mixed alpha and beta blocker for the hypertension and tachycardia. Very important to remember that you would use a mixed alpha and beta blocker like labetalol, not a pure beta blocker. A pure beta blocker usage is controversial as a first-line therapy because one of the ways that cocaine works is that it actually upregulates alpha activity. So if you have alpha-1 vasoconstriction and you block all the beta activity, you further enhance the alpha-1 vasoconstriction. So this URL question teaches you a little more about how all of this works. A 32-year-old man is brought to the emergency department by police after an altercation at a local pub. He's agitated and says that his chest hurts. His blood pressure is super high and pulse is 130 as well, and regular. On physical exam, he is combative and uncooperative. There are no signs of physical injury. His pupils are dilated and reactive to light. Nasal exam shows mucosal atrophy, which is pretty much the giveaway for cocaine overdose. And ECG shows myocardial ischemia, inhibition of what process is most likely responsible for his presentation. This man is presenting with acute cocaine intoxication. Cocaine and TCAs inhibit reuptake of monoamines like norepinephrine, dopamine, and serotonin, resulting in sympathetic stimulation. So you see the hypertension, tachycardia, mydriasis, and CNS activation leading to arousal, agitation, and seizures. Cocaine is also a potent vasoconstrictor that promotes MI through coronary vasospasm and causes local ischemia, nasomucosal atrophy, and septal perforation. So these are all the things that you would see in this patient in the scenario that we have, right? Now, your question, unlike URL questions, your question might not give you all the symptoms, right? But enough symptoms must be given for you to be able to pick cocaine overdose, right? So something is going to be there that's going to be very specific to cocaine rather than other things. Like here, they gave you the mucosal atrophy, nasomucosal atrophy. That was enough. Then they further gave you that he also has an MI, so that really was extra information. But the URL's job is to teach you. So here they summarized all the symptoms, and they did a good job with that. Next thing that everyone's pretty much addicted to is nicotine, right? Caffeine and nicotine are the two highest addicted things, and most people do both at the same time. What you'll see is a lot of people will get a coffee in the morning on their way to work, and then be smoking and drinking the coffee as they go, because it helps. The coffee helps them get rid of the tar. It's not going to be stuck in their mouth and stuff. And the add-on effect of both of them together is the restlessness. Okay, so if you have too much coffee and too much cigarettes at the same time, you're going to be super restless. But at the same time, this restlessness, a lot of people channel the restlessness into productivity, so they're able to get a lot of work done. Now, nicotine withdrawal is a much bigger deal than the caffeine withdrawal, right? And we've seen people suffer with both of these, either in questions or personally, or someone else that we know. Caffeine withdrawal, you're going to be super pissed off, and you're just really agitated, can't do anything, have a headache, and you're I need my coffee, right? Nicotine withdrawal is very similar. Irritability, anxiety, restlessness, and difficulty concentrating. Treatment for this is to start using a nicotine patch, and then of course you should always advise your patients to quit smoking, and you could talk to them about it, right? They can start taking bupropion or varenicline. And we're going to see these medications very soon. But what I do want to say is that bupropion is something you should not confuse with buspirone. Remember that buspirone has the bus in the beginning, and you're anxious, you're going to miss your bus. So buspirone is for generalized anxiety disorder. And varenicline has nicotine decline. Okay, so that's how you remember what varenicline does. And this is actually a pretty important medication. UWorld even made a diagram to teach it in a question they had. I'm going to show you that diagram when we talk about it later on. A couple more medications: LSD, marijuana, MDMA, also called ecstasy, and PCP. LSD is usually going to be related to someone who's going to some kind of musical event, like in Electric Daisy Carnival, right, EDC, or anything like that. Because what this does is it causes perceptual distortion, right, visual and auditory. So everything in a Electric Daisy Carnival and similar events, there's just colorful lights and loud music. All of that gets further amplified. Other than that, they don't do anything weird. So they're not going to be fighting anyone. They're not going to be trying to commit suicide. Nor are they depressed. Nor are they running around. Nothing. They're just really having this amazing moment of just nirvana. And there's no such thing as withdrawal symptoms for it, because people don't necessarily abuse LSD. They just use it for the events they're going to make those events more fun. Marijuana is something that's probably the third most commonly used on this list. And, although it's on this list, no matter what someone really says, marijuana is not really a problematic drug. Just like nicotine and caffeine are perfectly fine to use, right? So is marijuana. You can use it however you want, and nothing's really going to happen. And if something's going to happen, it was your decision to use it. Just like someone can keep drinking 6 cups of coffee in a day, and they can really mess themselves up because they love the taste and how it makes them feel. We're not making caffeine illegal. Someone can smoke so much that they actually die from it. We're not making nicotine illegal, so marijuana should not be illegal either. It doesn't do anything that bad. In fact, if anything, nicotine is far worse than marijuana. Marijuana causes euphoria, anxiety, paranoid delusions, perception of slow time, impaired judgment, and social withdrawal. It can also increase appetite, which is called the munchies, and it'll cause a dry mouth and conjunctival injection, really red eyes in someone that's really high, and hallucinations. But the hallucinations are very rare. Pharmaceutical form is dronabinol, which is used as an antiemetic in chemotherapy patients and can also be given to AIDS patients to make them hungry. Right? AIDS patients often tend to lose their appetite because remember, what makes you hungry is having fat. Right? Remember that the fatter person is going to be more hungry because if you have adipose, the adipose is the thing that's going to release the ghrelin to make you hungry. Right? And without the ghrelin there, you're not gonna be that hungry all the time. The other one, leptin, right? Leptin makes you thinner. These guys are not necessarily gonna have any of that balance that average people tend to have. So marijuana. One thing you want to remember though is that a lot of companies do this fucked up thing. They do a urine test for you before hiring you, which is really unnecessary, and they want to see if you do marijuana, and if you do, they're not going to hire you. So marijuana is actually metabolized by the liver and distributed and stored in lipophilic tissues and slowly released. So it can be in your body for up to 30 days depending on how often you use it. So you can't go in for a urine test at that point. And this is so much of a nuisance that people actually try to bring in urine that was either their friends or something like that with them to their doctor appointments instead of giving their own urine. It's like a common practice. Marijuana withdrawal is not a real thing per se, but if you're addicted to marijuana, then maybe you'll have irritability, depression, and a decreased appetite, but that's not a real thing. Ecstasy is called the rape drug, right? This is the medication that you might see in a question scenario where maybe there was a house party with a bunch of college students or something, any kind of party, and someone would try to slip ecstasy into a girl's drink or something to get her to have disinhibition, right? And then you can rape her. That's basically all this is really used for. It's a hallucinogenic stimulant, so of course it also is a party drug, just like LSD. It can cause euphoria, disinhibition, hyperactivity, and distorted sensory and time perception. Also bruxism, which might be in the question to help you grab MDMA as an answer. Life-threatening effects can include hypertension, tachycardia, hyperthermia, hyponatremia, and serotonin syndrome, but not the biggest deal here. All right, the last medication that's pretty commonly tested is PCP. PCP makes you a fighter, right? So you're going to be violent, impulsive, you're going to have psychomotor agitation, nystagmus, tachycardia, hypertension, analgesia, so you don't really feel pain, psychosis, delirium, and seizures. Trauma is the most common complication. Usually, PCP is going to be a drug that someone used in like a bar fight or something, right? They were using PCP, they went to a bar, they got into a fight with someone. And the trauma complication is from actually trying to restrain them, right? Trying to restrain them is very difficult. They will fight back very hard, and often it leads to trauma. The best result is from pharmacotherapy immediately. PCP is an NMDA antagonist. Secondarily, it can inhibit reuptake of norepinephrine, dopamine, and serotonin. So what is the pharmacotherapy? Because they didn't mention it. So UWorld continues to tell you, management of PCP intoxication mostly consists of supportive care, controlling breathing, circulation, and body temperature. Benzodiazepines like lorazepam are the drug of choice to control agitation and seizures. Treating psych symptoms is also important. Typical antipsychotics like intramuscular haloperidol are used for psychotic symptoms but may produce side effects such as dystonia. Now, where this haloperidol thing comes in handy is that you can get a question where they tell you, oh, an intramuscular antipsychotic was given. They're talking about haloperidol. This is mainly the only one that's really given intramuscularly, so be ready for that. Right? For LSD, however, LSD is managed in a similar way to PCP management, but haloperidol is still not recommended due to its many side effects. LSD also causes pupillary dilation. Activated charcoal may help within the first hour after an overdose. Not fatal. LSD is not that bad. Alright? Now, the last thing on this video was supposed to be a conversation about alcoholism and how it works, and then we have two questions at the bottom. Alcoholism works with these receptors over here, so you really need to understand how the alteration of these receptors leads to the symptoms we see. It's physiologic tolerance and dependence on alcohol with symptoms of withdrawal when intake is interrupted. That's when you know you're an alcoholic. Complications include alcoholic cirrhosis. The first thing you see is fatty infiltration. Then you start getting blebbing and so on, and more issues that can eventually lead to cirrhosis and cancer. But the first sign is always going to be fatty infiltration. Hepatitis, pancreatitis, peripheral neuropathy, and testicular atrophy, mainly because you're running out of testosterone binding globulin, right? Because your liver is not doing so well, and you're just not managing things well at all. Treatment for alcoholism is to use disulfiram, which is going to condition the patient to abstain from alcohol use because it causes hangover symptoms. Acamprosate, naltrexone to reduce the cravings. Support groups like Alcoholics Anonymous are major key. You have to remember to recommend going to support groups because it helps. Support groups are a major thing, and NVMe has been having a lot of questions where they throw support groups as an answer choice. The concept here is that support groups are used in all issues that are either emotionally involving or big conditions, right? Life-changing conditions. Alcoholism is both of those. So it really helps to sit down and talk with other ex-alcoholics who start talking about how their life is improving, what they're doing, how much it affects them, what's been happening, so that you can see others that are suffering with the same issue as you and then kind of deal with that, and you're not alone anymore in that aspect. So this is a very important thing to support in questions. Don't pick support groups as an answer choice if the condition someone has is not necessarily going to be helped by talking to other people with the same condition. For example, Alzheimer's disease, right? Having someone with Alzheimer's meet more people with Alzheimer's is going to be pointless because they're going to forget, right? Just think about it like that. So you do give support groups to people who might have just gotten lupus, for example, right? It's going to help meeting other patients with lupus because lupus is a huge systemic problem, and there's so much going on. It's very depressing to have lupus. So meeting others who also have it kind of makes you feel a little better, and then you get to see how they're dealing with it, and so on and so on. So support groups are very important to remember. We've already seen Wernicke-Korsakoff when we did our biochemistry stuff, right? So caused by vitamin B1 deficiency, triad of confusion, ophthalmoplegia, and ataxia is what defines Wernicke encephalopathy. This can then progress to irreversible memory loss, confabulations, and personality change, which is the Korsakoff syndrome. Symptoms may be precipitated by giving dextrose before administering vitamin B1 to a patient with vitamin B1 deficiency. So you always remember to give the vitamin first, right? There's nothing wrong with taking vitamins, but sugar is pretty dangerous. It leads to diabetes, right? So you could think about the fact that just give the vitamin first. There's nothing wrong with giving somebody vitamins. Then you give the dextrose. Wernicke-Korsakoff is associated with periventricular hemorrhage and necrosis in mammillary bodies. Both of these things which get tested, right? You might get a question about a patient who's an alcoholic, and then they'll be like, what would you see on MRI or CT, etc.? You will see the necrosis in the mammillary bodies. And if someone who has symptoms of being an alcoholic or a history of being an alcoholic suddenly presents with periventricular hemorrhage, is because of Wernicke-Korsakoff, not anything else, right? So you want to make sure you can make those connections. So what happens to an alcoholic patient? What is it that you need to understand? This table has neurotransmitters that are related to alcohol, what happens with acute intoxication, and then how your body deals with that acute intoxication once you become a chronic alcoholic, right? So this is what alcohol withdrawal syndrome is going to do. So in acute intoxication, acutely, alcohol potentiates inhibitory GABA A receptors, right? You can remember GABA A for alcohol. Alcohol potentiates inhibitory GABA A receptors, helping you feel sedation. Chronic alcohol leads to downregulation of GABA receptors. Since you keep activating the GABA A receptors, your body stops showing so many. So now you have fewer GABA receptors. When alcohol is no longer consumed, the fewer GABA receptors are so insensitive to GABA that the typical amount of GABA your body naturally produces is not enough, leading to physical withdrawal symptoms since GABA normally inhibits neural firing. So now you start getting seizures. Thus, GABA desensitization results in unopposed excitatory neurotransmission, and that sucks. Alcohol also inhibits excitatory NMDA receptors in the brain. So now you're not turning on your NMDA receptors at all, so your body decides to put out more NMDA receptors, right? So chronic exposure upregulates NMDA receptors. When alcohol is no longer consumed, the excessive NMDA receptors will be more active than normal, contributing to the delirium tremens and excitotoxic neuronal death. Alcohol withdrawal causes a surge in release of excitatory glutamate, which activates the NMDA receptors, right? So that's what eventually shows your delirium tremens effects after the 48 hours in alcohol withdrawal. Right, so really important to understand how alcohol works and the receptors and hormones involved. Make sure you can memorize this stuff and really, grasp it well. And to end this video, two questions from you, world. This one, 20-year-old college student is brought to the emergency department by his roommate. The patient is frightened and claims that the campus police are following him and plotting to kill him. His roommate says that the patient seemed totally normal until the past few days when he began staying up all night to prepare for final exams. The patient has no known medical or psychiatric history. His blood pressure is high and pulse is 110 on exam. He's pacing, sweating profusely, hypervigilant, and mildly slurred speech. What is the most likely diagnosis? And they made the answer choice really easy, substance-induced psychotic disorder, but the other answer choices were other psychotic disorders, so that's why they put that there. But when you see substance-induced psychotic disorder as an answer choice, you should be able to figure out something's wrong. There must have been some kind of drug this young college student must be using, because they were perfectly fine earlier, as per the friend's explanation, and they don't have any psychiatric history of something like bipolar or depression. Misuse of stimulants by college students to enhance academic performance is prevalent, very common. His paranoia, restlessness, hypervigilance, tachycardia, hypertension, and diaphoresis are most likely due to stimulant intoxication. Transient paranoid psychosis can develop in intoxication with all major stimulants, including prescription medications for ADHD, such as amphetamines and methylphenidate. Differentiation from bipolar manic episodes or brief psychotic disorder, which were other answer choices, must be made based on his prominent physical signs, lack of psychiatric history, and the temporal association between staying up all night and the fact that his finals week and now he has acute psychosis. Alright, that was a giveaway. Next one, 26-year-old woman is found unresponsive and not breathing on the bedroom floor by her father. Despite resuscitation efforts, she is pronounced dead in DED. The woman had recently returned home after an unsuccessful attempt to live independently and maintain employment as a waitress. She completed an alcohol and drug rehab program 6 months ago. Her father says, "I know she drank and used a lot of different drugs over the years, but I had hoped things were finally turning around for her." The patient had a history of depression and anxiety that was being treated. According to epidemiological data, overdose of which of the drugs groups is most likely related to her deaths. So this question really had nothing to do with any of this. This question is just asking you what's the most likely thing that can kill someone, drug overdose wise, in terms of epidemiology and statistics, and that's opioids. The majority of overdose deaths in the USA are related to opioids, and very, very famous people have been dying lately as well, either in isolation or with co-ingestants, which, this patient might have had opioids with alcohol, which just worsens things even more. The abuse of an addiction to opioids and heroin is a growing public health problem. Heroin, which kind of works like opioids, is cheaper and more accessible, so patients are transitioning to it. Alright, so we're finally done with this. Thank you so much for joining, and I've already done psych form, so that video is already up too, and then now we can start jumping into renal.